Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm pleased today to be talking with Janice Klein. Janice was the Director of Business at the Mount Lebanon School District, which is a suburb of Pittsburgh, Pennsylvania. She was in leadership positions for 37 years. She's now retired and has moved to San Francisco. Probably to get away from a little bit of the snow and perhaps some of the dreariness in the winter. Jan, it's great to be talking with you.
Oh, thank you. It's great to be here. Hopefully we can help some people do some good in their community.
I hope so too. So I want to take you back to the beginning. The very beginning, you were on the management side with the school board. And could you tell a little bit about how things got started way back when?
Well, when I was still a young pup in school business, one of the things we found as we put budgets together for our community, an ever increasing portion was going to healthcare. And we didn't seem to have any ability to control those costs. And wasn't sure why. We didn't know all of the details behind that because management of school districts tends to be a generalist position. You know a little bit about a lot of things, but not a lot about specific issues. And the more we realized that our rates were going up because we might have had one large claim one year, and the insurance companies would increase our costs tremendously the subsequent year, far beyond inflationary amounts, in order to recover the losses from the prior year. And this was happening in the Allegheny County and Pittsburgh area. It was happening to all 40 of the school districts. So we were all paying excessively high rates with huge increases, and we had no way to control that. Costs were going up to be about 10% of the budget, which was a huge amount in government. And we didn't have money to pay for things that we really needed, for salaries, for supplies, for things that the kids really needed to benefit from. So a group of business managers and HR directors in the county got together to try and band together thinking, well, bigger is better. If there were more of us negotiating with these insurance companies for healthcare, perhaps we would be able to mitigate some of those huge increases. What we learned was that a lot of the cost was to cover that unanticipated risk, the risk of having a large claim. So it was decided, well, let's get together and see if we can group together and maybe self-insure so that, one school district might have a bad year, but the other ones will be okay and they'd be able to mitigate those increases. None of us were large enough to self-insure on our own, but together we became formidable. It took a lot of doing. We had to get agreement of the larger school districts, because it was with their purchasing power that some of the smaller school districts who really desperately needed the help could become part of the group and begin to benefit from that type of organization. So that's what got us started back in the mid-90s. We developed a relationship with Heinz Foundation and asked them to help. They wanted us to be a fully labor management, equal voice grouping. But at the time, we couldn't get there. And you'll find that when you start any type of organization, what you dream of isn't always where you start. You start small. You start with what you can do. It was developed as a consortium of school districts that were management-led, but labor advised. So labor was on the board, but they didn't have a vote, and they were 50-50 represented in developing benefits in the plan. But even that was difficult because each of the 40 school districts had unique contracts. And some of them had 4 labor groups. So it wasn't just 40 different union contracts we were dealing with. It might have been 4 times that amount. So it was never something that was easy to deal with. And as long as it was management led, there was a bit of distrust by the labor groups. Like, what were we really thinking, and why were we really making the decisions that were being made? So we, we're not doing all that we could do. But we realized that if we had the help of the union groups, we would be able to make bigger changes, more useful changes. And so what we did was, in the early 2000s, we got together and said to labor, we'll go to our participating school districts and see if that we can vote to become fully labor management. A 50-50 leadership, 50% labor trustees, 50% management trustees. And we needed, I think, a 2/3 vote in order to get that. We were 1 school district shy. 1 school district too many voted no. And when we asked them why, what do we need to do? They said, well, school boards are paying all this money. We want school board representation. So it wasn't just management and labor, it had to be school district management and labor. So we added 4 positions for school board members and 4 more labor positions because it had to be 50-50. And it passed, just barely, but it passed. We got 1 additional vote. And that was really how we started down the path of really being able to save money for our school districts.
Yeah, at some point, Janice, it's my understanding that you got some advice and support from some brokers who had been trained in the Health Rosetta model. Could you speak to that a bit?
We had consultants that were helping us along the way because, as I said, well, the labor union, their background was in education. Our management team, all but 4 of them, our expertise was in school business. And 4 of the school board members could have been from any background at all, but they really weren't in healthcare. They weren't in insurance, healthcare insurance, which is really what we were needing assistance with. So what we did was we hired a consultant. I don't know whether I can say the name of the company.
That would be okay, sure.
Okay, we hired a consultant from Aon, and that consultant was able to help us understand the insurance business, help us understand behind the scenes what was going on. And he was also able to lead us to types of individuals, the Pittsburgh Business Group on Health, to educate us in things that were going on within healthcare that would help us make decisions about specific programs or issues that we had to surmount in order to get the results that we wanted. I'm not sure if that answered your question, but that was
yes, you did. Thank you. And so you went through this period, as I recall, it was something like perhaps 18 months, 2 years of doing your homework to understand things. And then what happened next?
Well, what we decided about insurance, healthcare insurance, and how the insurance companies make money, and how we could help control our costs by perhaps not letting them make quite as much. I mean, they should make a profit, but not completely at our expense. So what we did was we decided that we couldn't fully get our hands around our costs unless we only had 1 or 2 plans. As it was, we could have had 100 different plans because each labor contract, including within different school districts, each school district could have had multiple healthcare, different ones for the teachers, then for the bus drivers, and so on. I mean, you have to understand that, we had food service workers who sometimes were part-time. We had clerical workers. We had custodian. We had so many different groups, and each of them had different contracts, sometimes with different labor unions. But somehow, if each one had their own type of benefits, we couldn't determine whether their costs were higher because perhaps they had one extremely expensive contract, or whether it was because the cost of whatever their benefit package was more expensive. So we decided that the best way to do that was to limit our risk pools. And what that meant is everybody had to have the same contract. Now, we had no ability to go to the schools and say, you must have these benefits in your contract. But what we asked them to do, and what the labor unions were wonderful with, was we asked them to point to our consortium and say, the Allegheny County Schools Health Insurance Consortium is the plan that you get in your contract. And that freed the consortium to make changes every year if they had to the benefit plan. So if we found that giving free access to primary care doctors was a benefit and it caught illnesses early, then we were able to put that directly into our plan, and then perhaps charge more to go to specialists in order to get people to realize they have to go see their doctor first, their primary care doctor first. But we couldn't do that with 100 different plans. So that was one of the things that we had to do. The other thing we found was that there were certain hospitals in the area that were more expensive than others. Like for a simple knee replacement, it might have cost $30,000 at one hospital, and it might have been over $100,000 at another hospital. And it was sort of a eureka moment. It was, at least for me, it was like, well, why don't we develop a program that it encourages people to go to the less expensive hospitals and charge them more if they go to the more expensive hospitals. And one of the labor leaders said, I can't support that. He said, I can't support that because my people will say I gave them cheap insurance. He said, now if it were based on quality, that would be a different story. And it was a moment that we all sat and thought, are there quality measures for healthcare? And can we rely upon them? And if we did, what would they tell us? And that is when we discovered our path towards quality in healthcare and developing our plan for our now 2 healthcare plans for our 16,000 employees and 50,000 belly buttons that we covered. How do we get them healthcare that is inexpensive but high quality, the combination of the two? And it's a program that we continue today. The consortium continues working with them today on that. I'm not sure exactly how far you want me to go into that, but that was a big difference for us. That was a big jump for us.
My understanding is that you were able to find data sources that gave you that kind of information. And I'm assuming that the brokers might have been helpful helping you discover where that data is available. And that then got factored into the decision-making. And in my understanding also, Janice, is that there's 2 big systems in the Pittsburgh area, UPMC and Allegheny Health Network / Highmark. And my understanding is that the consortium decided to go the way of Allegheny Health Network Highmark. Do you want to comment at all about how that decision was made?
Well, at the time, there was a little spat going on between the two organizations, and the contracts between Allegheny Health and UPMC were being canceled. So we had to choose one over the other. We couldn't choose both at the time. Things have changed since, but at the time, that was the situation we were looking at. So we hired a consultant to help us maybe develop our own plan where we could choose certain hospitals based on quality and cost within each plan. And they did a study and came back to us. And as a result of looking at that study, and the details of that I cannot release publicly, but the details of the study led us to believe that our most effective path at that point was to go with the Allegheny Health organization. And it was something that brought our costs down significantly and increased our quality metrics overall as we moved forward.
Right. So what kind of savings are we talking about here?
Well, before we implemented this quality program where we had a narrower network focused on quality, our cost savings, and if you'll excuse me just a little bit, I want to pull out the numbers so that I can look at them. Before we went into this program, we were spending about $5 million in our highest quality ranked hospital in the Pittsburgh area. And for an almost exact number of services, we were spending $15 million in one of the lowest ranked hospitals in the area. And then after we implemented our plan back in October of 2015, it switched. We were now spending $7 million in the top tier hospital, the highest ranked quality hospital in the area. And we were down to only $5 million in the lowest ranked hospital. People saw the quality data. They saw the tiering in our program where it was essentially free to go to the higher quality hospitals, and you paid more to go to the lower quality hospitals. We knew they were more expensive, but people were choosing based on quality, and they made a choice. They went away from that. It's the huge difference. We went from a spend of $241 million in 2013, and we went down to about $232 million in 2014 and 2015. I mean, we were able to control those costs and keep them down as people learned about quality and making choices.
So that's an interesting point that you raised. One of the challenges I would expect is while you and your colleagues who are making the decisions have been well educated now up to this point, how did you deal with the issue of educating your members so that they were making better choices?
Communications is key. We have a quarterly magazine that goes out that describes a lot of what we do. It looks like a healthcare magazine. It's, like what you would buy in the corner grocery store. And we would send that to everyone's home. Additionally, we put in a product called Healthcare Bluebook. And you could go in there and they would show you the high quality, low cost providers. And if you chose them, we would send money. Even if it was completely a free service, we would send people money so that they would choose one of these lower cost, high quality providers.
Janice, could you say a little bit more about that? What do you mean you would send them money?
Okay, well, the program that we developed with healthcare Bluebook was that, and let's just pick something. Let's say I need to get a colonoscopy. I don't know why we always discuss those, but that's what the organization always focused on. I guess because of those of us who are older are always getting them, who knows. But let's say I needed to get one. If I have it in a freestanding clinic, with all the care that's, medical care that it is, it might cost me a couple $1,000s for the consortium. It's free to me as a user, but it's a couple $1,000s for the consortium. If I choose with the same doctor to do it in a hospital, it might be $8,000. That's a huge difference. So what Healthcare Bluebook would do is it would look at the doctors and look at their quality ratings and see if they had this lower cost option. So it would provide you with quality ratings for the doctors as well as quality ratings for the places. And if you chose one of those lower cost places, one of the freestanding clinics, you would get a check in the mail for $100, $300, whatever was determined at the time. And that happened, just because, you chose a high quality, low cost option. And people love that because they didn't actually have a charge for the colonoscopy. It was free in our plan. It was 100% covered in the plan, but they got money back because they were sharing in the savings that the consortium had.
I have to believe that's a powerful motivator.
That is a powerful motivator. Yes.
Wow. So I'm looking at the case study that's in Dave Chase's book, Relocalizing Healthcare. And I'm looking at the describes your plans. Program provider, and there's a second opinion service. Could you speak a little bit about that second opinion service?
Certainly. We actually had a number of different companies that would do that over time. We started with Best Doctors, and what we told our people is that if you get a diagnosis that is serious and you're concerned about it, let's say I got a diagnosis for heart surgery or cancer or a knee replacement. And I was concerned that I was not getting the full story. I didn't fully understand why they're saying I have to have surgery or I have to have a certain kind of a chemotherapy. I could call this company, 100% paid by the consortium. So it cost me as a user nothing. They would go over my medical information, and they would contact an international team of the best doctors in that field. So if it was a specific kind of cancer, they might have an expert in that specific cancer rather than just someone who treats cancer generally. And I would be able to get a second opinion where they would review my tests. They would describe what alternatives were, what cutting edge treatments were for that diagnosis. If they needed additional tests, they would recommend them. The case study would go to the doctor as well as to me, so that the doctor was part of it. They didn't treat me. My doctor, my local doctor, treated me, but he then had all of the information. He or she then had all of the information that was available from the internationally known experts in the field. So those are the types, and there are many different companies out there, that do this kind of program, and that gave our people, who weren't quite sure whether to have surgery or not, someone to talk to. Sometimes that costs the consortium more money because instead of surgery, they would recommend something else, or instead of physical therapy, they would recommend surgery. Or they might have a cutting edge therapy that was in fact more expensive than what the typical treatments were. But it didn't matter, because if you treat the person right the first time, you don't have to treat them 20 different times. So over the long run, you have a healthier employee back at work, feeling good. And even if it cost more, it was a better choice for our employees and their families. So that was the path that we took for that purpose.
Thank you. So from what you said, there were savings after in 2014, 2015. You probably saved somewhere in the neighborhood of $8 to $10 million per year over the previous costs.
But we saved about $10 million, but that's assuming that the costs wouldn't have gone up. We might have saved more than that had the costs gone up. So that's something that it's unusual to actually see your total costs, which were close to $2.5 million, actually go down. I mean, who has that? No.
So what's your sense of what, I mean, that's a lot of money to put back into the schools. What happened with that money?
Well, we were able to limit increases in healthcare, cost increases in healthcare. And the school districts were ecstatic, because that freed them up from having to pay increases in healthcare. They were able to negotiate better contracts with their teachers. The teachers were happier because they were able to get money in salaries rather than in benefits. And we also became wildly popular within the Western Pennsylvania region, and had to sort of change our charter to accept more schools in counties surrounding Allegheny County. So we are no longer only Allegheny County, we are now all the counties that are, touching Allegheny County. And there's typically a wait list of schools waiting to join us, because we have excellent benefits, often better than what they have, and often at a less expensive cost. So because we got hold of those things that were charging schools more, and we were able to become educated and help our people join us in controlling healthcare costs.
Could you comment, what's your sense of the importance of primary care, of helping your employees, the members of the plans, understand, appreciate the value of primary care?
It is absolutely one of the key strategies we used. Rather than having a $20 copay or a $10 copay, we made primary care completely free to our members, completely free, so that people didn't have to worry, well, can I afford to go to a doctor? They had to pay to go to, they had to pay a lot to go to an emergency room. They had to pay to go to one of these clinics, the urgent care clinics. But they paid nothing to see their doctor. And that focused all of their care in one place. And people took advantage of it. We saw that people would change the behavior and go see their primary care doctor whenever possible. And we feel that they had better care because of it, because, they may have gone there because they had a cold, but maybe there was something far more serious that they would have never caught had they not been with a doctor who understood their entire healthcare background.
Janice, I want to bring things to close, and thank you very much for this. It is my hope, as I said to you earlier, that other school districts and other employers will learn from this, learn from your experience. From what I can tell from my interviews and my reading, you guys put a lot of time and energy into developing a new approach that I think that can inspire others to similar ends. And if we end up with better school systems, better early life development for the children who will become the adults in the future, to me, that's another benefit that comes out of this. Long term, the nation needs better schools, and we need a better educated population.
I couldn't agree more. And if we can avoid putting money in an area that provides no additional benefit, I think that that is a great way to start. And focusing your money on benefits that help the employee and their families be well, be better faster, get the best healthcare that they can without putting money in that doesn't need to be there. That's absolutely a great place to start.
So Janice, thank you very much for this. I really appreciate you talking with me today, and thank you for the work that you and your colleagues did to make this happen. This is not an easy thing to do.
You are welcome, and thank you for getting the word out there, because hopefully if even one other community is helped, we will have done a good job for that. Thank you.
Beyond that, thank you very much, Janice.
You're welcome. Bye now.